So that's the background. That's the overview of the valvular diseases. Now we're going to go through 4 of them, and we kind of mentioned a little bit here. So there's mitral stenosis, aortic stenosis, mitral regurgitation, and aortic regurgitation. It'll make sense what each one of these are. Mitral stenosis is going to be this. So mitral stenosis, little pinhole there. Okay? Stenotic. So this is the most common severe valve disorder. Okay? The mild one we'll talk about later, but this is the most common severe one. And it's due to rheumatic fever because the valve cusps actually fuse together. Okay? It can be caused by bacterial endocarditis. We talked about that. And the way the pathogenesis is, and this is where you got to go step by step. So you can put your pencils down and just follow over here with that picture I got over there. So you have mitral stenosis. Okay? So the amount of blood that's going to go from the left atrium to the left ventricle is going to go through that little pinhole, which means there's going to be an increased workload on the left atrium. Does that make sense? A lot of pressure that this left atrium is going to squeeze and push it through that little pinhole. There's a lot of work for this little guy. So therefore, we're going to have a decrease of filling of the left ventricle. Does that make sense? Less blood going into the left ventricle. That's going to make the left atrium start to close hypertrophy, right? It's going to get a bigger muscle. It's got to squeeze harder against that little pinhole. This muscle in here is going to get thicker. Does that make sense? Right? Which means you're also going to increase the left atrial pressure, which kind of goes together with all this. All right? Going against that little pinhole. If there's more pressure in the left atrium, then there's going to be a backup of blood here, which means there's going to be a backup of blood in the pulmonary veins, which means there's going to be a backup of blood in the lungs. The person will have pulmonary edema. And if that's long-standing, a year or so, then that can actually be carried off and turned into right heart failure. Because now you can't push, the right heart can't push all the blood forward because of the backup. Does that make sense? Right? So, again, this wouldn't make any sense if you don't know the blood flow to the heart. So that's why I said, make sure you know the blood flow to the heart before you even entertain valvular diseases. Okay? So, manifestations. Makes sense. You're going to have short of breath because you have pulmonary edema. Your heart, because there's going to be a decrease in cardiac output, your heart wants to pump faster to try and get as much blood out into the bloodstream. Does that make sense? So you're going to have tachycardia. You're going to have angina, chest pain, because there's going to be less blood going into the coronary arteries because there's less cardiac output. You get dizzy, syncope, fatigue, okay? This can lead to atrial fibrillation. Now, we're going to talk about this too. Fibrillation is basically, it's uncoordinated, very rapid heart rate. But we're just talking about the atria. So what will happen is, normally it will do this. Very coordinated, not too fast. Fibrillation is this. And the problem is that blood could stay in there longer because it's just circulating in there. You need a good hard squeeze to push it out. But when it does this, it's like weak contractions. So the blood can actually form clots in there. We'll talk about that. It can cause myocardial infarction. And myocardial infarction, I should have put it this way, but myocardial infarction, if there's less blood flow going to the coronary arteries, it can cause necrosis to the muscle tissue. Depending on where it is, but the left heart might not be able to pump anymore because there's less blood flow going to that part of the muscle. So you could have a myocardial infarction that leads to a left heart failure, which will lead to right heart failure. Does that make sense? You can have both on there. All right. Questions about mitral stenosis. So I have like 2 slides for each one of these diseases before I go further. Is that okay? Okay. So let's talk about aortic stenosis. All right, aortic stenosis is have that, but now you got a pinhole through there. Okay? You could visualize the setup here and what's going to happen with signs and symptoms and backups, right? Aortic stenosis, it's due to rheumatic fever, as we talked about. And it can be caused by a congenital malformation, which we'll talk about, birth defects kind of thing. And also degeneration resulting from calcification. So if there's a lot of calcification going on, it'll go around, let's say, this valve over here. And calcifications are hard, rocky stuff. So that's going to make it very difficult for this to actually open up because there's a lot of calcification, a lot of hardness going there. So that's what we see on there. Regurgitation, we do the same thing, you know. And as I do this, look over there and you can see it all together. So if you have aortic stenosis, now you're going to have an increase of workload to the left ventricle, trying to, you know, the left ventricle is going to try and squeeze all that blood into that little pinhole. There's going to be more work going on there, which means that the left ventricle is going to dilate because there's going to be more blood sitting in here. This is going to dilate. Does that make sense? Because it can't get through there. But because the heart is trying to also work hard, it's going to have dilation, there's the extra amount of blood, but you're also going to have hypertrophy because it's trying to push through that little pinhole. So you'll have both on there, okay? You'll have a prolonged left ventricular contraction. Because it's going through that little pinhole, this left ventricle is trying to, that little train that can, you know, the little boat that can. So it's going to squeeze for a long time trying to get in there and then relax. So it's not going to do this. It's going to squeeze for a longer amount of time. It's trying to compensate, okay? So the heart gets overwhelmed by all this. You're going to increase the left atrial pressure, because if there's a vacuum of blood over here, there's going to be a vacuum of blood over here. The left atrial pressure will increase. It'll go backwards into the pulmonary veins, into the lungs, and again, it's very similar to what you just saw with mitral stenosis, right? So you're going to have all the shortness of breath, all that stuff, and it can lead to right heart failure. Okay? So manifestations. You'll have a decrease in stroke volume. Make sense? That little pinhole, if this is starting to contract, you're only going to have a little bit of blood entering the aorta. That blood that's going to go out there, that's stroke volume, and it's going to decrease. You're going to decrease the systolic blood pressure. Now, think about this. This contracts, little blood going out there, a lot. Little, okay? So what will happen is, if let's say the person's, our blood pressure is usually, let's say 120 over 80. It should be less than that, but let's say 120 over 80. What will happen here, the blood pressure that's happening here, all the arteries are going to try and compensate during diastole. So the bottom number is going to be about the same. It won't change. But during systole, when the left ventricle squeezes, only a little bit of blood goes out there. So what's going to happen here is that it's not going to reach 120. It may only be, I'm just giving you numbers. It may only be, let's say, 90. So what happens to the pulse pressure? The pulse pressure is 40 millimeters of mercury. Over here, it's 10 millimeters of mercury. It gets a very narrow pulse pressure. Does that make sense? This usually stays about the same. This goes down because there's less blood going out there. And because there's less blood going out there, when you try to feel the person's pulse, it's going to be very faint because there isn't that much blood that's going out there. So it becomes a very faint, or I wouldn't say pulseless, but it's going to be difficult to feel the pulse itself, whether here or wherever you're going to be feeling the pulse. Okay? And the heart rate will decrease also. They get angina, dizziness, and so forth. And the same thing, it could lead to arrhythmias, myocardial infarction, which will lead to left heart failure and right heart failure, and so forth. Okay? Questions on that? That's aortic stenosis. So, now we'll do mitral regurg. Okay? In a case like this, what we're dealing with is this is normal. So the aortic valve will be normal. But the mitral valve, it's going to kind of be like that. It's floppy, and it goes backwards. All right? So mitral regurgitation is due to rheumatic fever, as we talked about, all right, bacterial endocarditis, and mitral valve prolapse, which we'll talk about in a moment, okay, and cardiomyopathy, which is a genetic kind of disease, which we'll also talk to. So the pathogenesis is here, right? Mitral regurgitation, there's going to be a reflux of blood from the left ventricle to the left atrium, right? So when this contracts, blood is, and think about it, what's going to happen is when, if there's a, again, I'm just going to use numbers again. 100 milliliters is here, you squeeze, there's going to be, let's say, 50 milliliters going out there, but let's say 20 milliliters will go this way too. When 70 should go out there, does that make sense? But some of it's going to go backwards. All right, so there is some blood that's going out there. So we're going to increase the blood in the left atrium. Then the left ventricle, now just listen to this one. The left ventricle and the left atrium pump harder to move the same blood around. Meaning that when this contracts, if 50 milliliters goes out there, 20 milliliters goes here. Now this has got to squeeze the normal amount here plus the 20 milliliters back into here. When this squeezes again, the 20 milliliters will go back this way. You see it's going back and forth, right? So that's what this is all about. And this is going to cause, because there's X amount of blood there, it'll cause the left ventricle and the left atrium to cause hypertrophy. It's going to increase the left atrial pressure, which leads to pulmonary edema, right heart failure, and so forth. Right? Making sense? Okay? Going back and forth, manifestations, it'll try to compensate. Going back and forth with all this, it's going to try and compensate by making this, we have hypertrophy going on both places, but this gets to a point where it caps off. It can't go anything more. And when that happens, there's going to be less blood going out here because this cavity gets smaller because of the hypertrophy. Does that make sense? This is going to get thicker and thicker and thicker, which makes this cavity smaller, which means the stroke volume is eventually going to get less, which means your cardiac output is going to be less. All right? It compensates, but it gets capped off. It's going to increase the systolic blood pressure. Why? Because there's nothing wrong with this valve, but you have a lot of hypertrophy here. So you're going to have a nice, strong contraction. You're going to put a lot more blood out there. So what happens here is that, again, if our blood pressure is 120 over 80, what will happen is, again, the blood pressure that's out there is going to compensate where the diastolic pressure will still remain about 80, but you're going to have a pounding amount of blood that's going to go out there. So this 120 may be, and I'm going to exaggerate, but let's say 180. So what will happen is the pulse pressure is going to be 40 here, but now you have it as 100. So this pulse pressure widens. Does that make sense? As opposed to narrow. Okay? And you get edema, shock, palpitations, and so forth. Okay? Fatigue, shortness of breath, and all that. Okay? Any questions about mitral regurgitation? You okay with this? Sorry there's no pictures. That's why my only pictures is here. There's really not much to see with this. It's just visualizing what's going on. Okay. So now we're going to do aortic regurgitation. So it'll be, I'm kind of doing it before. Okay. So now we've got the problem here, where there's going to be a backflow of blood this way. due to rheumatic fever, right? Bacterial endocarditis, syphilis. So you should be starting to make, you know, most people think syphilis, oh, it's a sexually transmitted. It is a sexually transmitted disease, but it's not just the area down in the sexual area, but you'll also have problems. Remember we talked about syphilis also causing dissecting aneurysms, right? With that whole thing. It can all, we're talking about tertiary syphilis. It causes brain problems, all right? So think that syphilis will also cause this too. High blood pressure, okay? If you have a lot of blood pressure in the aorta and all the other places, so now the pressure is higher here, so you're going to have a backflow. It's going to be pushing that aortic valve so that it's going to go backwards because there's so much pressure up there. Does that make sense? Okay. So the pathogenesis for this, all right? Aortic regurgitation. You're going to get a reflux of blood from the aorta to the left ventricle, just what I have up there. It's going to go backwards. That means we're going to increase the amount of blood in the left ventricle. Following? Okay? That's going to make the left ventricle work harder to try and push that extra amount of blood. That means the left ventricle is going to have hypertrophy, get thicker, the muscle. Eventually, what will happen is there's going to be a back of a flow here, back of a flow here. You're going to increase the pressure in the left atrium. It's going to back up into the lungs, pulmonary edema, and you get right heart failure. All right, is that okay? Increase the stroke volume. Why? Well, you have more blood going back here, but you're going to make this left ventricle much stronger. So there's going to be more blood going here. It's going to squeeze harder because the muscle's just thick, and you're going to increase your stroke volume. Does that make sense? There's more blood going to go out there. It's going to do the widened pulse pressure because more blood is going out there. And you usually have, when you feel the blood or the pulse, either here or wherever you're going to feel it, it's usually a pounding pulse that's happening, like bam, bam, and you can feel it being very pounding. All right, you'll get angina, palpitations, and so forth. Okay. Questions on that? No? You all good with this? It's like the other class was very quiet too. You know, but it's a lot of material. But it's all, if you're following, if you understand the blood flow, it should make sense. Okay? All right, the other one I just want to say very briefly is mitral valve prolapse. Okay? In that case, it's this mitral valve that's going to prolapse. It's not a strong, it's kind of like a mitral regurgitation, but on a mild scale. Okay? And most people are asymptomatic. They don't even realize that they have it. This is the most common overall valve disorder in the United States. Mitral stenosis is the most common severe one that we've been talking about, where it causes like pulmonary edema and so forth. This one, about 3% of 20 to 40-year-olds have this. Okay? Most females, more females than males have this. It's idiopathic. But with something like this, most patients are asymptomatic and they don't suffer from anything. My roommate in medical school had this. You can listen to his murmur and stuff, but he was asymptomatic. He had it, but he played college or baseball in college. So that just shows you how severe this is. It's nothing really. It's not going to be, you know, like life debilitating. The only thing is we have to watch it because there is a certain percentage of these will lead to mitral regurgitation. So that's why we would just want to watch it. But if it's just prolapse, and you can diagnose it with the echocardiogram, they can play baseball, there's no problem. Okay? So in most patients, it's going to be asymptomatic. It's an incidental finding that we see. You may get, if there's symptoms, you may get palpitations, tachycardia, you get syncope, atypical chest pain, a whole slew of different things, anxiety, depression. But it may, what we're concerned about is that we have to watch it only because it can progress to mitral regurgitation. Okay? Questions on that?